so much for joining this first webinar series. This will be the first in a series of 8 webinars that will include presentations from Oxford, from the Health Systems Collaborative, as well as from colleagues at the University of Mohammed 6. So the first presentation is going to be by Mike, talking about the Clinical Information Network.
Just for those who've never met me, I'm Mike English. I trained as a pediatrician, spent 25 years living and working in Kenya doing research, and now back in Oxford, where I'm part of the Health Systems Collaborative with Catherine and others on this call. And I'll lead you through a set of work that took a long time in the generation. So it's termed the Kenyan Clinical Information Network, and the whole aim of this now almost 15 years ago was to start what we thought of as a low-cost learning health system. And I've recognized all the institutions at the top there you can see, but particularly I was based in the Kemri Welcome program in Nairobi and worked very closely with the Kenya Pediatric Association, the Ministry of Health and the University of Nairobi on this project. For those of you not so familiar with Kenya, I'm not going to spend any time on this, but the bottom line is when this started, Kenya was still a low-income country. It's now transitioned to be a low-middle-income country, but is at the bottom end of that categorization, and you can get some insight into its per capita health spending there. It has gone up a little bit since this figure was made, but it's still about $110, $120 per person per year, so not exactly enormous. Still a very young population, and a very restricted number of healthcare workers, which is relevant to the work I'm going to talk about. Other things about this context: certainly when we started the project, things have improved somewhat. The typical African district hospital, which includes those in Kenya, might have anything between 150 to sometimes up to 400 beds. So these are not small community hospitals there. They are general hospitals expected to provide surgical services, pediatric care, neonatal care, obstetric care, etc. But they have often been very poorly resourced. So I've indicated with a green tick where things may be available and a red cross where they're not available. Where there's both, it means they're intermittent. So you can see that for basic things like the availability of oxygen, the ability to do a chest X-ray, and the ability for an infant to do nasogastric feeding, that was pretty much universal most of the time, not always perfectly available in terms of quantities. But for many things, the availability was much more partial. So, for example, even now, it may be difficult for these hospitals to do a blood glucose test, even for an inpatient, as often as they might like, and sometimes they would not be able to do it at all. And some things which in some settings might be considered just standard routine care, equipment like having a syringe driver to deliver fluids and medicines for a sick newborn, for example, or even for any age group for that matter, were almost never found. And well, we'll talk a bit about neonatal care and pediatric care as much of the focus. And really, there was no intravenous nutrition of any sort available, and is still largely not available in most of the settings we're talking about. So that's just to give you some idea of the context. And another important feature is that there are no functional electronic medical records. And although there are now types of electronic medical records, they rarely cover inpatient areas, because obviously that's the most difficult thing for highly functional inpatient medical records to do. So going right back to the beginning of this approach, if you want to understand, if you want to improve care, which is part of the aim of a learning health system and the clinical information network, you have to have the, if you like, recommendations for what people should be doing. You have to have an agreed standard of care. And so what one of the things we were doing very early was bringing together the health community around pediatrics and child health in Kenya, to actually develop standards of care. And this was using an evidence-based approach. I think Kenya was the first country in sub-Saharan Africa to use the grade approach, which we introduced actually before WHO introduced it to its guideline development. And we used we had many participants in developing national guidelines, which I'll go on to. And in fact, some of the work that was done in Kenya then led to the creation of this first WHO book. It contributed to that development. And this is a process that's gone on in the background to this clinical information network for now quite a long time. So over a period of over 15 years, there's been an awful lot of guidelines developed or updated. We've deliberately included non-researchers, non-academics in guideline development panels, and very large numbers of people in guideline decision-making panels. So these have taken various forms over the years, becoming more sophisticated over time. And the bottom line is that Kenya now has a fairly robust system of developing at least pediatric and neonatal guidelines, which in the latest iteration was a process that was entirely led and directed by the government, linking with the University of Nairobi, and with some support from the research team, but actually rather little. These guidelines, which I'll show you in the next slide, have been turned into simple protocol booklets that many people can carry around with them. They're very easy to reproduce, and you can actually put them in your pocket. Guidelines are useful, but to enable people to use them, they need to understand what they're supposed to do. And so training materials are developed linked to the guidelines. It's called ETAP Plus. Some of the people on the call have had quite a lot of role in delivering this. And if you're going to run good training, you need to have people who know how to train, and cascade training is something that I do not believe in. And so essentially, with the development of this training course, it was also important to develop a cadre of high quality trainers who could reliably and consistently and effectively deliver the course content. So this was essentially an iterative process, as I say, over about 15 years, that has always gone on in the background and fed into what the Clinical Information Network has been doing. And so, as I said, these guidelines were turned into small booklets, which could be mass produced and delivered and shared with young clinicians, doctors. We have clinical officers who are a form of non-physician clinician, and also nurses. So all of them could carry these booklets. They're obviously now available in smartphone apps, not produced by us, I hasten to say, but it's all available online. And the booklets which contain the guideline documents, or the simplified guidelines in forms of literally algorithms, were part of all the training approaches, so that they were getting used to using the guidelines during the training. And with colleagues from University of Nairobi, the training was then entered into the medical school for all undergraduates and postgraduates, and has now, in fact, has evolved to, it has been shared across multiple medical schools in Kenya and into Uganda, Rwanda, and some other countries. This is all a process that I'm no longer involved in, and it's largely led, or at least coordinated, by the National Professional Association in Kenya now, together with the Ministry of Health. So I wanted to present that background because it provides, if you like, the foundations of, well, if you're asking people, if you're explaining to people what is the right thing to do, and giving them the guidance for the right thing to do, and then training them on how to do the right thing, that's all very well, but does it actually get into routine practice? And so part of the next phase of all of this, it was running concurrently but started a little later, was to develop these ideas around learning health systems. So there are various versions of what learning health system means, or how it's interpreted. We started with the definition that was produced by what was then the Institute of Medicine in the US. It's now the National Academy of Medicine, I think. And it has these 4 principles that underlie a learning health system, that essentially you only use one data source, and ideally that's the routine data system. So researchers don't come in and create parallel data systems. You're trying to foster improved practice, and therefore you would be trying to help people implement things that they are supposed to be doing. And if you can do the first 2, and particularly if you can create the data system, then it allows you to do more rapid clinical research, because you're not having to constantly reinvent databases. And that research can make use of hopefully reasonable quality observational data. But you can also then layer on top of this more specific interventions, but use the same data system and the same set of, in our case, hospitals, to do interventional research. So I'll talk a little bit about that. But the final point, which I won't spend a lot of time on, was also critical, is actually the whole point of a network is that you're creating, and what it's referred to in this principle as engaged stakeholders. So they are part of the system, not just the recipients of what's going on. So right at the beginning, in the development of all the guidelines, I hope you could see that there was extensive engagement with the professional community. That's not just medical people, but also nurses, clinical officers, policymakers. So they were engaged from deciding what should be the standard of care, if you like, and what particular clinical practices should be done in this level of facility, the district hospital. But they were also involved right at the start of setting up the clinical information network in a workshop to say, well, what is its purpose? What's its vision? What's its mission? How's it going to work? And essentially what throughout the lifetime of the clinical information network, with the exception of the period during COVID, network members, so people from hospitals, that's typically the whoever is in charge of pediatric or care within the hospital, pediatric or neonatal care, a senior nurse from the same department, and importantly, the health records information person. We brought people together at least once a year, and quite often twice a year, so that they could review what was going on, but also make decisions about what it was important to tackle, so that they were part of agenda setting and, if you like, benchmarking performance against their peers and having the opportunity to discuss what they were trying to do and whether it was working and maybe how to make it work better. So, as I say, this was based on the learning health system principles, but it was also, if you like, formulated as a theoretically informed intervention strategy. So although it was a network, there was an effort to theorize how it should achieve its results. And that was done in advance of setting it up. So we tried to state what our thinking was, how and why it should work before we started trying to do it. But on the right hand of this screen, you can see what we meant by a network, and again, it comes back to this issue that there are very many definitions of networks now, as well as learning health systems. This was a horizontal network, if I can call it that, in that we were linking multiple hospitals up the same level of the healthcare system. So it was not a primary care network with a hospital linked to multiple smaller facilities. It was as I say, a horizontal network. Because our aim was to try and promote improved practice in these county public hospitals, as they became known, and they were formerly district hospitals. So they were our target. We were the Khemri Welcome, and you can see our roles were project management. We were essentially bringing in the funding, not surprisingly, but we were also managing a lot of the data. Khemri Welcome is a government, at least comes under the umbrella of a government body, so it has a sort of para-governmental status, We were clearly working with the Ministry of Health, and you can see I've illustrated in the graphic there that several key departments that we had to work across all of them, and in fact quite a few more. So there was a lot of engagement with the Ministry of Health over many years. And we were also conscious, and part of our theory was that actually the government can say what should happen, it can set policies, but actually there's a very important set of people who are highly influential about whether any policies, particularly when it comes to more clinical or health policies, are actually used or adopted at the professional communities. And we engaged, as I say, with educational people, those who are educating health professionals, but also those who are regulating them, that's the councils, and those that were representing them, if you like, more like trades unions, and those were the associations. So the aim that the network was bringing all these partners together in the hope that there was some common purpose. So again, we could talk a lot more about this, but I'll try and do it very briefly. So top left of the screen, you can see the icon for the pediatric protocols. These were linked to, we didn't have electronic medical records, so what we did with the professional community was standardized paper records, and that's a little bit, you can see a section of that you can see there, which is an effort to structure at least the admission process, which is typically done by the most junior doctors or junior clinicians, so that and most of the clinicians who go and provide frontline practice in these district hospitals have only had 6 or 8 weeks training in their entire 6 years to do with pediatrics or neonatal care, and so most of them had forgotten pretty much all of that by the time they actually came to be on a ward. So the purpose of these structured record forms was to remind them what to look for, to link that to the protocols, which suggested that if you see one of these things, it means you should probably do this. But then also it becomes, as you can see from its structured nature, much easier to get data from these medical records, which were not provided by the research team. These were actually the hospital's medical records. So we never took any of these things away from the hospital. What we had was people in the hospital entering data into a REDCap system. So this data were only collected once the patient, in this case the child or the newborn, had exited the hospital, hopefully more alive than died. But we used adopted principles from clinical trials management to try and optimize data quality. So as I say, all of the data that are collected and all of the data I'll refer to in the rest of the talk was actually captured by essentially intern doctors and intern or qualified clinical officers. There were no, except for the occasion, for some specific trials, there were no additional data collectors in the hospitals. So it is routine, optimized routine data. I won't go into the system for all of this, but feel free to ask me questions later. But if we were getting data entered daily, quite a lot of data on admission characteristics, treatments, tests, and discharge characteristics and discharge outcomes. And with this, we were able to develop reporting systems that allowed us to feed back to the hospitals every 3 months on what the network had felt were sensible quality of care criteria. And therefore, what we were able to do is, from the central team, is provide the hospitals with these reports, but we were not doing any quality improvement ourselves. And what we asked, what we essentially were asking the hospitals to do, and particularly the team members who were part of the network, typically a pediatrician or a medical officer in charge of the ward, the senior nurse, etc., was for them to try and do the improvement that they could. And just to say that although I've put PDSA cycles in here, which people will recognize, it was actually quite rare that hospitals could run a quality improvement team and a PDSA cycle. We were often providing the information on what was changing, so our quality metrics, could inform them, but often they were having to make quite specific decisions in quite small groups, because having a true quality improvement team working is, because of the personnel challenges, was often beyond what was possible in these hospitals. So they were often much more ad hoc improvement processes, than these very specific QI type strategies. So I mentioned we had some key personnel, and one of the early pieces of work we did on who it was important, and feeding into the theory around why a network should work, and who we were really expecting to enable changes to be made if we were going to do improvements within the learning health system, was work on what I've referred to as mid-level managers in the management literature, and as we came to learn, often called hybrid clinical managers in the healthcare literature. And this is where you can have people who are extremely well trained clinically, often, with several years postgraduate training in a particular area like pediatrics or even neonatology now, but nobody actually explains to people that what they will really be doing is running a team of people. And so nobody actually explains to them what's the important skills you'll need to run a team, and how do you do it in practice. So we did some work from a more theoretical perspective, largely led by my colleague then, Jacinta Nzinga, but also this fed into the way we had network meetings, and what we actually ran some specific training sessions on how they should do coaching, or how they should run a team meeting, etc. So we were trying to articulate to the network members, the leaders in each of these hospitals who were functioning at the mid-level, a different skill set that they might need if they were actually to make improvements locally. And so over the period of this learning health system development, we continued to refine our ideas on how to make things work in these horizontal style networks. And I won't go through all of this, but not surprisingly, as we learned things, our ideas changed, although not enormously. I guess we began to learn more about other people's thinking, other people's theory, and reformulate our things in line with some of these theoretical perspectives. The most recent work being that one at the bottom, which is actually Catherine's, using realist approaches to understand how relationships are critical to the way programs work. So what I've been through with you so far is represented by the infographic on the left. So starting at the top, we had evidence-based practices which were agreed. We had standardized medical record forms. We were moving around clockwise. We were then, if you like, doing quality improvement style work, but really that our job as the network is to provide the performance information rather than do the QI locally. But we decided that the nature of the indicators was agreed, and sometimes the focus of our particular feedback was agreed with the membership of the network. We were trying to foster peer learning and networking, partly, as I say, as a sort of informal benchmarking, but also so that people could share ideas about what was and wasn't working, and learn from one another. And I mentioned that we were doing more specific skills training, or partners were doing more specific skills training, particularly for the more junior staff. And actually often some of the senior staff, particularly the pediatricians, became the trainers, and were training not just their own hospital, but in other settings. But we were also, as I say, trying to mentor if you like, provide a sort of distributed mentorship to the people that were trying to actually to change things in the hospitals. So that was how the network was operating. And then the final part was actually layering on top of this whole thing some research, which I'll come to. And we've articulated some of our reflections on what it's like to use a learning health system, again, in pieces we've written a couple of years ago. So some quick examples of the type of improvement work So again, on your left of the screen, and this was the early days of the network, with the hospitals that were involved, they came to set targets for what they wanted to achieve, and we gave feedback on the progress. And if you look at the red line, the red dotted line, that's essentially the average of across all the hospitals that were involved, the average monthly performance against, in the top left panel, it's the proportion of children who had their HIV status known and confirmed as when they were during their admission. And initially you can see way back in 2014, this was routinely not really happening. And within, it took about 18 months for the hospitals to hit the target that they had set themselves of 80%. So same for malnutrition screening and more formal evaluation of malnutrition status over roughly the same time period. It took about 18 months. Performance wasn't quite as high, but was considerably better than baseline. Moving on to the panels on the right, these were somewhat later in the network where work was getting a bit more sophisticated. The top panel is after some co-design of nursing charts, which were initially left out of the standard chart development process. So one of our Kenyan colleagues did a lot of co-design work with the nursing community, and then implemented in what was supposed to be improved nursing charts. And I hope you can see that there was some improvement in the recording of nursing vital signs. They're still by no means perfect, but there was a significant change. And in the bottom was more of an output or indicator, is over a period of 3 years, again with an effort of constant feedback to hospitals in terms of the performance that they were expressing, what was happening to the proportion of babies admitted to newborn units who were hypothermic on admission. And there is a slow and steady decline. Again, still could do better, but over time things do appear to have improved. And as I say, the role of the network was simply to provide the indicator information back to the hospitals and not to do actually any of the improvement work itself. However, having all of these data allows you to uncover interesting variation. So again, the panel on the left is examples from 2 hospitals, work done by another colleague, Alavala. And if you look at the blue line, you can see that in the one hospital represented on the left between January 2021 and September 2023, the blue line hovers around 40%, but it's a bit up and down. That blue line is the proportion of babies admitted with probable neonatal sepsis who get first-line antibiotics. And the green line is the proportion that get second-line antibiotics on admission. So the hospital on the left is actually not doing very well, and the hospital on the right, by our criteria, is doing much better. So the blue line, approximately 80, if not 85%, or even 90% of babies are getting the first-line antibiotic for this condition, and actually relatively few are getting second-line antibiotics when they don't need it. So you can actually pick up quite substantial variations in practice between facilities, which then allows you to target facilities for particular interventions. The plot on the right, I hope people are familiar with the idea of funnel plots. So this now is pivoting to mortality outcomes. So each spot on this plot represents the mortality proportion for a specific hospital. And the red line is, if you took all of the hospitals, the average mortality for this particular weight group admitted to newborn units is about 43%, which is very high, obviously, compared with high-income countries. But you can see that each hospital, very few hospitals are bang on the average. They have values that are spread around the average, as you would expect. The values which are outside the blue lines represent values that would not be expected by chance if the hospital mortality was essentially a random sample from a common population. And what this tells us is that you can see that there are some red spots in which this weight group has a mortality of around 60%. And there is a blue and a black spot where the mortality for this same weight group is about 30%. So there's a twofold difference in outcomes for the same type of baby across these hospitals. And the value of these plots is they can begin to show you both what is achievable, i.e. getting down to a mortality of 30%, because these have common resources, and which facilities might need to work very hard to bring their mortality down. And these are some of the first types of these analyses that are reported from sub-Saharan African hospitals. I'm now going to talk a little bit about how this same platform was then used for studies of a more research nature. So obviously Kenya is a malaria endemic area, or at least parts of the country are, and I suspect everybody knows that there is a malaria vaccine, and malaria vaccines need to be tested. And so because we were collecting high quality routine data from one part of Kenya, which has a lot of malaria, the team were partnered with WHO and other countries to provide data on severe malaria in assessing if you like, a large-scale implementation study of one of the malaria vaccines. So we were able to share data with WHO about the numbers and types of severe malaria cases that were being admitted to hospital, and look at whether or not those children admitted with severe malaria had vaccines or not. And so the data from this clinical information network contributed to this multi-country study on the effectiveness of the vaccine, which, as you know, was effective. So it's now been recommended across malaria endemic areas of Africa. More recently, colleagues you've probably got the idea that the clinical information network was focused on pediatric and neonatal care, and that is correct. But obviously, when COVID arrived, COVID was a disease of adults, and so colleagues used exactly the same mechanism and essentially added a network component that was based on adult medical wards, and used exactly, as I say, used standardized charts, used the same data system to capture data throughout the COVID period. So we were able to pivot very quickly, or add very quickly. Within literally 6 weeks, we were able to get up and running a surveillance across 12 hospitals within 6 weeks of the start of the onset of the real pandemic in Kenya, to get surveillance up and running across 12 hospitals in Kenya. And this provided the opportunity both to say what was going on in terms of COVID admissions. And I guess the first thing to say is that what became rapidly apparent is that none of these hospitals, even though they're quite big, none of them was actually able to test routinely for COVID. So they were admitting a lot of patients with severe acute respiratory infection, but very rarely being able to confirm whether or not it was COVID, because they simply did not have access even to rapid tests. So counting the number of COVID cases was extremely difficult. But what it then prompted was the need to do a randomized controlled trial of whether steroids should be given in African populations for severe acute respiratory infection when you did not know whether or not it was COVID. I'm sure you've all heard of the Discovery trial, which said that if you've got COVID, you should get steroids, and it helps reduce mortality substantially. But that's in cases where COVID was confirmed. What happens if you don't know whether it's COVID or some other disease? So this was a pragmatic trial, giving steroids to all patients with severe acute respiratory infection, irrespective of etiology, which was almost never known, and was able to enroll 2,000 adults really quite quickly. And in this recent publication showed that giving steroids to undifferentiated or people with an unknown pathogen who have severe acute respiratory infection was beneficial. So that has allowed Kenya and hopefully other countries to change their practice and be more confident to give steroids to this class of patients. And another colleague, excuse me, is in the process of writing up the final report for a study in which 4,000 children with severe pneumonia were individually randomized to alternative treatments, because there has been almost no, so I think this study will increase by about 8 or 9-fold the number of children who've ever been in a trial for treatments for severe pneumonia, because despite the fact that it's one of the major killers, there's been almost no trials on what treatments to give. So this trial is about to report, and as I say, it used exactly the same platform of routine data, and was conducted, both of these trials were conducted with people in the hospitals as co-investigators. So those are individually randomized controlled trials. We've also been able to layer on other forms of interventional study, one of which is led by another Kenyan colleague, in which we randomized hospitals rather than individuals. In this case, the aim was to try and reduce gentamicin prescription errors, which are actually surprisingly common in sick newborns, because most doctors only learn about dosing for adults, and they might learn about dosing for children, and then they take that knowledge and just apply it to newborns, and it's not quite that straightforward, sadly. So it's more complex to prescribe gentamicin as a drug to newborns, and so there are actually quite about 20% of newborns who are prescribed gentamicin as a drug get the wrong dose, or at least they're prescribed the wrong dose. So this is a cluster trial testing different forms of feedback to try and reduce that proportion. And I'm going to come on to tell you a little bit about the quasi-experimental study in a second, but it's another example of how we were able to use the platform with the surveillance information that we were capturing to link to other needed forms of investigation. I'm just flagging these up. So throughout, colleagues have continued to do different forms of health services or health systems research on the same platform that we now, in terms of platform here, is the hospitals that we've developed as partners. So we've looked at the difficulty of getting blood cultures done and why that will remain very difficult, even if people buy lots of blood culture machines. We've looked at how patients move through the system and all of the challenges there are as you move through the system that we rarely pay attention to, and clearly a clinical guideline usually refers to a very specific point in a care process, but doesn't cover how somebody should move from the outpatients through to their final ward, which may include going through laboratories, imaging centres, etc., etc. And as I say, we've continued our interest in the roles of managers and whether they like to be managers or not. So this graphic was created about a year ago, and overall, at that point, the Clinical Information Network had captured data on about 650,000 admission episodes, which I think probably makes it the largest database of its kind in sub-Saharan Africa, outside sort of DHIS2-like systems, because this is individual patient data. You can see that the majority are children and then newborns, and a good number of adult episodes captured. So it's been relatively low cost. We've used it to inform policy. It feeds back into the guideline development and standard setting cycles with the Ministry of Health and others. There's been some improvements in practice, and it has allowed us to check how things have evolved over time, and also provides this platform for more health systems research. So we reckon it's a good idea to have this kind of network. Unfortunately, it's extremely hard to get funding for it, because it's not a specific technology, it's not a specific intervention, etc., etc. But we can talk more about that later, perhaps. And I want to quickly, very rapidly, I can see time is moving on, turn to something called the NEST program, which is an effort to upgrade neonatal care services, and by providing technologies, by helping people, by doing implementation research, by creating the market for new technologies, and in the human resources field to focus on education and trying to improve, if you like, the knowledge and skills of practitioners. So we were interested in this because we'd done some earlier work. So if you think about a nurse on a neonatal unit, you can see in the infographic that a nurse on a neonatal unit looking after a sick baby has multiple things to work with, to manage, as well as obviously the family and maybe looking after quite a few of these babies. And so while upgrading neonatal services seems like a great idea, we had some concern that the efforts, while addressing some of the challenges, such as providing better materials, maybe addressing some of the team issues in terms of quality improvement and addressing some of the workforce issues in terms of people's knowledge and skills, were they tackling all of the important issues? And the graphic, the scatter plot you can see here, on the y-axis, it talks about the numbers of nurses on the newborn units, and this is on a shift. And on the x-axis, there's an indication of the volumes of patients over a single year. And the x-axis is a log scale. And for those of you who understand these graphics, what you should see is an exponentially rising curve where the number of nurses on a newborn unit rises exponentially as against these admissions on a log scale. And you do not see that. You see pretty much a straight line. In other words, the numbers of nurses on neonatal units is by no means related to workloads. And the dark blue spots on this graphic are public hospitals, which have the highest workloads, highest volume of babies, and relatively the lowest number of nurses. And it's the public hospitals where the NEST intervention was taking place. So if you think about the outcome for an individual baby, lots of things have to go right. And a lot of those things that need to go right over periods, sometimes well in excess of 1 week, will depend on what the health workers are capable of doing. So we were particularly interested in the roles of health workers in these settings. So we did new studies in 8 hospitals, and I'd like to focus your attention on the pink highlighted rows in the table, the average shift level nurse to patient ratios. So this is neonatal units with CPAP machines, with incubators, with phototherapy. So these are sick babies, often premature, and you'll see that one nurse was typically looking after around 1 in 20 sick newborns, sometimes as good a ratio as 1 in 10, but also as bad a ratio as almost 1 in 40. So essentially staffing is extremely poor. And in these units, very careful work done by the team in Kenya and others. If you take those ratios and you convert those ratios into how many minutes a nurse has for each patient on a 12-hour shift, the average is about 30 minutes per patient. And so if you've got 20 babies, the implication is you might have 30 minutes for each of those 20 babies. Clearly, it doesn't quite work out like that. People concentrate their time and prioritize their time. But this is a very optimistic assumption, because this assumes that the nurses have no breaks and have no other responsibilities other than looking after the babies. And just as a sort of benchmark in studies, admittedly, of infants, when they've done time and motion studies, they've reported that it takes 120 minutes to correctly set up a CPAP machine, get it onto the baby, and do all the observations that are required to initiate CPAP. So that's the 120 minutes to use one machine, admittedly a more complex machine. And so if you spend 120 minutes on that, then you're not spending it on other babies. So what this data showed then was that when people elucidated or counted all of the care that was happening and compared it with what was supposed to happen to the babies, basically about 1/3 of neonatal nursing care gets done by nurses. 1/3 gets done by students or mothers who are not given training and supervision necessarily, and there's a 1/3 of care which never happens at all. And if you take just the example of giving intravenous drugs, arguably in neonates, a skilled procedure, about 4 in 10 of those doses were given by unsupervised students, and these students would often be only on the ward newborn unit for about 2 weeks. So they were not highly experienced individuals. And in the table, you can see what was often done and what was almost never done. So you can see that the nurses prioritized technical aspects of care. And to cut a very long story short, because time is running out, we did a study where we added nurses and added then what we call ward assistants to see if we could improve the situation. The bottom line is, in the bottom left graphic, is that even if we added a reasonable number of, well, what we felt was a reasonable number of nurses, that we could afford, we didn't think it was reasonable actually, what we could afford, we actually only marginally increased the time available per baby. So it's still basically completely inadequate. We were able to measure a small increase in nursing care delivered, but this was moving the dial from very poor to somewhat less than very poor, but still poor. And nurses carried on, not surprisingly, having to prioritize what they did, and tended to focus on technical tasks rather than relational tasks with mothers, etc. And I'm not doing justice to all the work that was done on and represented in this one slide, but to give you an idea of the impact this has on nurses themselves of being in such stressful environments, it's enormous, and it's not surprising that they're poorly motivated and sometimes resistant to change, because they're basically trying to survive emotionally, psychologically, and financially. The ward assistance was an interesting one politically as much as anything else. It's hard to show a quantitative effect of adding them because they were not doing nursing work. But in general, they were very positively received. And because in these settings, in Kenya at least, this layer of personnel has often been stripped away, so that nurses were having to do often very basic, non-technical tasks. And this was an argument that this layer of the health workforce should be reintroduced to support nursing. So what we learned in progressing our basic understanding from the clinical information network into this is that you need better staffing. And if you're going to get any substantive changes, you need better staffing. And if you don't have better staffing, you'll continue to get poor practices, quite often unsafe practices, and sometimes falsified practices. So it raises the question, what's the basic level of quality and safety we should have before we try and do anything new? And I don't think I'll go into that. I'll just say thank you very much, because I think we've run out of time. So a lot of people involved, and thanks to everybody, and apologies for taking up too much time. Over to you, Catherine.
Great, thanks, Mike.